Okay, I'm going to share my screen, and it's just you and I, which is actually going to be good.
Yeah.
Yeah, others will probably join in.
Yes.
Okay, so let's do. Okay, and in fact, I actually also have Robin sitting here as well.
Hi, Robin.
She's coming to get stuff done. Oh, Keith, how are you?
I'm not talking to
you. Keith's a bit upset with me because there's a picture of Keith which was taken 30 years ago, and it turns out it's only 20 years old.
Ah.
Hi, Keith.
Morning, Jeff. Sorry, I just had to unmute myself.
That's all right. I did love your picture though the other day.
Yeah.
I'm sure that's 30 years old. Okay, so with no further ado, okay, we've got Becky's case here, so feel free to make comments here, Keith. Okay.
Okay.
So Becky, explain. Apart from the piercings, what else is unusual with this girl?
She doesn't actually have lip competency.
Yep.
Yeah.
Yep. Okay. Let's examine her face in just a little bit more detail.
Yes. I think she's mesofacial.
Yep.
She has a shifted midline. The teeth, the upper incisors, the midline shifted to her right.
Yep, and you can tell that by the philtrum of the upper lip. Yep, perfect. Good. Is that a concern to her or not?
No, it's not a huge concern. I mean,
I wouldn't have thought so, but
no. I think when I pointed it out to her, she said if it could be corrected, that obviously she'd like that, but obviously she's not super concerned.
What about her just general smile arc?
Yeah. So she used to be a thumb sucker.
Yep.
So hence, yeah.
Now, when you say she used to be a thumb sucker, because just about everybody sucks their thumb.
Yes.
Okay. When did she stop sucking her thumb? Because I think that's the most important part.
I can't remember actually asking her exactly when, but she just says she was sucking her thumb for a very long time. Okay. So she remembers it.
Yeah, because one of the things that we talked about in Module 7, we'll probably talk about a bit more in Module 3, is those type of forces, like thumb sucking, digit habits. Even when we start talking about tongue thrusting, it's based on the force and the duration.
Okay.
Okay.
Yeah.
Because that's what's going to cause an orthodontic force system. If they finish when they're about 5 or 6 before the upper incisors come through, it's unlikely it's going to be very detrimental to them.
Okay.
Unlikely. Okay.
Yeah.
It's more once the permanent teeth come through that we have an issue. Okay.
How about structurally? Because you know how it obviously teeth move bone as well.
Yeah, and once again, that depends on the intensity of it.
Okay. Yeah.
Okay. So if it's because I did have one patient, and you never want to make examples of one patient, a Afro-American kid when I was in Philadelphia, who actually distorted the entire palate.
Oh wow.
Okay, and so that was a really severe, intense thumb habit, with obviously a duration involved in there as well.
Yeah.
But it's not the norm.
Yes.
Okay, so.
The other thing, Jeff, here is I just want to ask you, obviously, I don't feel like she has any buccal corridor. She doesn't have much of it at all.
Precisely. Yep, exactly right.
But how would you describe her arc? Because I feel like it's not quite symmetrical.
Yeah, look, it's a bit hard to tell here, okay, because we don't have the eyes, because we blocked them out, okay, because that gives you a much better idea of some symmetry as well. But there's no doubt she's got what we would call dark buccal corridors. Her actual smile arc is not too bad. The upper incisors are not too badly positioned with regards to the wet lip line. Yeah. But when you look at the right-hand photo, you could probably intrude them a fraction. But you've got to remember that you actually want, 2, 3, 4 millimeters of incisal display at rest. That gives that youth appearance. We don't want to bury those upper incisors.
Yeah.
Okay, but she is showing quite a little bit of gingival display, which is aesthetically not too bad, but it looks like those buccal corridors. We'll have a look when we look at the intraoral photos. But it looks like those upper posteriors are basically just tipped lingually a bit. And so as soon as you put your arch wires in, you're just going to broaden it.
Yeah.
So it'll be pretty straight. I think that'll be pretty straightforward.
Yeah.
So when we look at the Ceph, I reckon she's a bit more dolichofacial once we look at the Ceph.
Yes.
And that wouldn't surprise me, because when I look at her from the facial aspect, she's probably got a little bit of a longer facial height.
Okay.
When you look at the thirds, but it's not a big deal. Okay.
Is the dolichoness also due to the fact that she's got incompetent lips? Like if her lips were closed, then that would then be different.
Yeah. Exactly right. It would be very rare for a brachyfacial patient to have incompetent lips, because they've got a short lower facial height. So the longer the lower facial height, the more likely the lips are going to be incompetent. Yeah. Okay. Once again, it's degrees. Yeah. Because when she's when she's got her lips together, the problem with incompetency, with lip incompetency, is mentalis strain. Yes. When the lips are together, and she doesn't have a great deal of mentalis strain.
So I did have to tell her to put her lips together when I took that photo, because otherwise it would just naturally be open.
Yeah, but when she has got her lips together, she doesn't have that mentalis strain.
Okay, yeah.
Okay, so which means that she doesn't have to really, really force her musculature to close.
So when I'm doing my assessment, when I'm taking photos, Jeff, do I want them to, and if they've got incompetent lip, do I want them to try and
close
get them together?
Yeah. You want a picture with the lips relaxed.
Okay.
And it's also a great idea to have a picture with the lips closed.
Okay, yeah.
Okay. So when we look at her OPG, we can see that this is the issue that we're going to see intraorally, her lower right 5.
Yeah.
But according to this, she's a class 2 skeletal. Would you agree?
Yeah.
Yeah.
And lower incisors look a little bit proclined, a little bit, but
Yes.
And the uppers are a little bit proclined as well. So let's have a look at it intraorally, because this is where it becomes very, very interesting. Okay, so she's got narrow arches. Okay, so before we even start on that, okay, and I'm jumping the gun, but the position of those anterior teeth, is that good or bad for what you're going to want to do, which is arch expansion?
I think bad, because they're already a bit proclined.
Okay.
That's true.
Okay, I'm going to take that aside for a sec, Keith. Okay. I'm just looking at the rotations. Remember, you want to look at the most displaced tooth in the arch. Okay. So in the upper arch, we've got this upper right lateral, which is rotated, correct?
Yeah, that will have a constrictive force on that center in front of it.
Yeah, but what will it have on the?
It will expand.
It would expand it.
It'll expand it. So this is a case, in all honesty, where you don't, how we would normally say put power chain on early on and derotate that lateral?
Yeah.
I don't want to I want to let the wires do that as long as possible.
Okay.
Because the reciprocal effect, as I put when I put the bracket on and the wire's going to come out here to the buccal, it's going to actually help us in giving some arch expansion.
Yeah.
So that's what we would call a consistent force system, consistent in what we're trying to achieve. Does that make sense?
Yeah, it does, yeah.
Okay, so that's what you want to be looking at. Which teeth do I have to correct really quickly, or which teeth do I just keep on? Yeah. So this is why we want to be able to assess it and then decide what we need to do to move the teeth. Okay. Okay. So here we are with the lower right 5. This is going to be the real issue. Okay. Okay. So here we are with a deep overbite that we're going to need to correct, and you can see that curve of speed. Okay. So you can see
Yeah.
that deep curvus B, which we're probably going to need to correct. Okay.
Yeah.
Okay. So here we are on the left-hand side. So we've got a posterior. We've got a bit of a posterior crossbite on the left-hand side.
Yep.
So, and we've got a class 2 canine relationship on the left-hand side.
Yeah.
Okay. Okay. And you said that your upper mid, and remember you said your upper midline was off to the right.
Yes, that's correct.
Okay. So now on your left-hand side, would I get?
Oh, sorry, I had it in the same image.
Okay, great. So your left-hand side is a class 1 canine,
Yes.
and basically a class 1, and you would argue it's probably a bit of a minor class 3 molar relationship, correct?
Yes.
Okay.
Yeah.
Okay. So here we are. Okay. So here we are with a deep curvus B. Okay. So tell me, well, this is going to be a bit of an issue here. Your crossbite on your left-hand side that we need to correct.
Yes.
Ideally, okay. So now we've talked about this before, Beck. So Keith, what do you reckon? Extraction, non-extraction? Remember, and what teeth would you extract if you had to extract?
Okay, I would probably try doing non-extraction.
Of what? Totally or?
Yeah, I would try non-extraction, nothing.
Okay. Now how old's this patient, Beck? 19.
Yeah.
Oh, are they 19? Are they?
Yeah.
Okay, fair enough. Okay, well, okay, let's say, so if we're going to do extraction, I'm going to have to think about that for a minute. So.
Yeah, that's fine. That's fine. Okay. So, because this is a really interesting case, I think. Because Beck, when you first brought this up, you thought about extractions, didn't you?
Yes, I did.
Okay. So, the problem here is we've already got a class 1 canine relationship here. Okay. So if we extract that lower tooth here, okay, that's going to make that if there's a bit of space left over, our midline's going to move across a little bit to the right. Okay. Okay. And whereas if we could open that space, which is a bit heroic, I might add as well, because we're going to have to push these anterior teeth forwards. Okay. Because when I look at it clinically, I don't see those lower incisors procline like I do on the Ceph.
No.
Okay, and so I'm going to go by my clinical guide here, because if I can move these teeth forwards, open up the space for that lower right 5. Okay, I can move. So if I can move these teeth forwards, I can get my premolar into a class 1 position. Okay, I can distalize my molar a little bit to get it into a class 1 because it's a little bit class 3. It will help to open up that bite and level that curvus B a bit more. Okay. And then my question is, what am I going to do on my upper left-hand side to correct that class 2 buccal relationship?
I'd have to extract a premolar, and I'm thinking it's the 4, but then I don't know if by extracting the 4, if that midline shift on that right-hand side midline, I know it's great. It's going to work really well when we start shifting it to the left.
Yep.
But am I going to overcorrect that and then I'll have a midline on the left? So then I'm thinking, is it the second premolar that I should be considering?
You know what? Your logic is totally correct. Okay. So this now just boils down to mechanics. But before we do that, so Keith, would you feel comfortable in extracting a premolar on that left-hand side, upper left?
No, personally, I wouldn't, but that's because I don't understand. I would, if you expand the arch, you could get a little bit of space, could you, to move that canine distally?
But you've got to remember you're probably a 5 mm class 2.
Yeah. Okay. So.
Yeah. So I'm not saying you can't do it, but
Yep.
predictability wise and heroic, because I think because you've hit the nail on the head in one way, Keith. The critical path to success here is getting a class 1 canine.
Yeah.
Okay, and so that's what we've got to focus in on. How are we going to do that?
Yeah.
So if your argument is we're going to expand that upper arch, and we're going to get it that way, And if you believe in the theory, well, when I expand the upper arch, my mandible's going to move forwards, okay? Which happens probably maybe, I reckon, 1 in 20 cases.
Okay, fair enough.
Yeah, it's just not predictable.
Well, when we procline those lower incisors,
Yep.
we get more anterior space.
Absolutely, absolutely. But I'm looking at just doing a unilateral extraction.
Okay, fair enough.
Okay.
Let me.
So and you're probably gonna need some crossbite elastics on this upper left 6 as well. Okay. But you can see how that 6 is really tipped in lingually.
Yes.
Yeah.
So your question here, Beck, do I take the 2.4 or the 2.5? Okay. And this now comes down, and we talk about this more in module 6, about anchorage requirement. Because if we take out the 2.5, you're more likely for that upper molar to move forwards more.
Oh, yes.
Okay. If we take out the 2.4, you're less likely. Okay. Now, but if we take out the 2.4, you're more likely then for the upper midline to move further across to the left. Okay. So now you've got to say to yourself, let's get okay. So you've got about 2 to 3 millimeters that you want to move it across.
That's right.
What happens if you move it across too far? Let's say you take out your 2.4, for argument's sake.
Yeah.
What could you do? Because this is one of the things that you would need to monitor during the treatment. So let's say your upper midline is going a little bit too far off to the left. What would you do? Because if it's going too far, let's say it's going too far off to the left, okay, that would imply, so I'm just going to get the left-hand side photos, okay. So if it's going too far off to the left, okay, that would imply that your posterior teeth are not moving forwards enough to get to a class 1, correct?
Yes.
Okay. So what could you do?
Could you do maximal anchorage on the front? Sorry, just tie one of those wires around the front to anchor all the teeth together.
Like a common tie.
Yeah, so tie all the teeth together.
Yeah, I'm not a big believer that works very well.
Okay.
I know that's what people teach, and the reason I say that is because that's a longer discussion there, but how much force do you need for a tooth to move?
Is it 80 grams?
Yeah, sweet FA, basically, right? So you tie it together, you're still going to have a force system, and in fact, if you look at it from an academic point of view, if you reduce your force level, right, and you anchor those teeth, you can actually be more likely to move your posterior teeth forwards.
Okay.
So, how else can you change your anchorage requirements?
The turbo bites?
No, it's really quite simple.
Okay.
So
Add composite? No. Would that be?
No. Your upper midline is moving too far to the left, okay?
Yeah. Can you, something to do with the wire? Do you put a stop on the wire?
Yes, not really.
Okay.
Because even when let's say you put a stop on the wire and I've got power chain on there, the whole segment's still going to move around.
Yeah.
It's really simple. Okay, if your upper midline is moving more to the upper left, right? What's happening to your right buccal segment? What would be happening to your right buccal segment at the same time?
There's going to be a gap there.
Well, I'm assuming everything's moving around.
Well, okay, yeah.
Okay, so your upper right buccal segment is what is moving forwards into more of a class 2.
Yes.
Yep. So if you start to see your upper midline moving across, once again, if you look at the canine relationship as being the critical one, if you start to see your canine getting more class 2, you back it up with class 2 elastics on the right side.
Yeah.
And if you're worried about your left side, you can run class 3 elastics on your left side.
Yeah.
Yeah.
So you can do a combination, depending on what you're seeing with your canines, you can run elastics to back up your anchorage.
Could you not cause a cant by doing that?
Not if you're wearing, Not minimally,
Okay.
but it's pretty unlikely because if you're wearing class 2, if you had an anterior midline elastic, okay,
Yep.
that's where you tend to cause cans.
Okay.
Because let's say you had an anterior midline elastic, okay, that was going from this upper left canine to the other side, that gives you a lot of extrusion of this area.
Yeah.
Because that's a lot of vertical force. If you're running these asymmetrical elastics, you're not really going to get as much of those extrusive forces. Okay? So that's all you got to do. So whether you take out the 4 or the 5, I don't think it's a big issue.
Okay.
Provided you, I think your 4 is going to be easier.
Yes.
But then you just monitor your elastic wear.
Okay.
Does that make sense?
Yeah, absolutely. But when I take out the 4, and I know that obviously for every force there's an equal and opposite force.
Absolutely.
There's a chance that molar, I know that we're trying to correct the molar on the left-hand side of the crossbite, but there's a chance that class 2 will get worse.
You're gonna finish off. Whenever you take out a 4, you actually finish them always in a class 2 molar relationship.
Yes.
So, which is fine. A class 2 molar relationship is not a problem at all. A class 3 molar relationship is terrible.
Okay.
I'll show you in one of the other modules.
Okay.
But a class 2 molar relationship works very nicely. Your problem though is, so let's have a look at your occlusal view. Okay, that's your occlusal view. Okay, your problem is here. See how your 6 is palatal 7?
Yeah.
Right. So as you put your restrictive force on your 6, you're going to tend to rotate that in, which is all fine. Okay. When you finish with a class 2 molar relationship, you actually want it to be rotated a little bit mesial to the palatal. It actually locks in a lot better.
Okay. Yeah.
But you're going to be fighting this transverse issue. That's the problem.
Yeah.
So you might you might want to start off non-extraction. Because you need to open up the space here on that lower right, and start running a cross arch elastics on that upper left 6 as well.
So at which point would I know I need to start taking the tooth out? When everything's pretty much aligned?
Yep, I think so. So yeah, I would get everything aligned. Because if you had crowding here, right? If you had severe crowding, I would say take the tooth out first, because the teeth are going to come too far forwards and you're going to round trip the case. You don't have a great deal of crowding here.
Yeah.
Okay. So I would keep the tooth in place. Okay. Start lining up the lower teeth, and then once you've got the lower right 5 in, the bite's opened up, take it, because by this stage you should be in like a 20 squared or a 1925 night eye in your upper arch.
Yeah.
And then when you take out that 4, you can really quickly proceed to your 21 by 25 night eye, and then drop back and close your space on your 1925 stainless steel. So you won't lose any time in this type of case, because if you're still lining up the teeth.
Yeah.
Okay.
Yeah.
And then you can make a better decision. Do I take out my 4 or my 5?
Okay. Yeah.
Okay. And we can have a look at it at that point. I just want to try and correct that crossbite as quickly as I can. And by having your 4 in place, okay, and your 5, and you have your straight wire in there, your 6 is more likely to come out, because you've got these other teeth there which buckle to your 6.
Yeah.
Does that make sense?
Yes.
But you will need bite turbos on it as well.
Yes. And in this case, I would put them on the upper 7s.
You could put them on the upper 7s. Yep. You could put them on the upper 7s or on the upper canines.
Upper canines. Yeah.
But the upper 7s will probably be much easier, in all honesty.
Yeah.
All you basically do, and I can go through that with you on Thursday. But it's just basically like a blob of composite on the occlusal of the upper 7.
Yeah.
Don't try putting it on the buccal cusp of the lower 7s. It's just too difficult.
Yeah.
Okay.
Yeah.
Do you feel see when you see this curvus B here, see how that lower 7 is a little bit over erupted? Because that's pretty normal with a curvus B. So you can do a little bit of intrusion of that by having your composite on the occlusal of the upper 7. So you get.
Do I need to go as far as setting up doing a intrusion arch in this case on the lower?
I don't. I think that's a bit of overkill. I don't think your curvus B is that bad.
Yeah.
But you've always got that as a backup method.
Yes.
Okay. And and the intrusion. I'll tell you where the intrusion arch can help you. Okay. Is when you do where it could help you, is when you have an intrusion arch in, you have a tip back on. You have a tip back bend, correct?
Yes.
Okay. And that tip back bend is going to do what? It's going to tip back that molar.
Molar back, yeah.
So it could help you, but all you need to do really is put your molar tube on, and just angle it a little bit more mesial to the gingival, and that will induce extra tip back just with your bracket placement.
Yeah. Yep.
And you get an open coil spring in there as early as you can. I don't think it's that severe that you're going to warrant a intrusion arch, but you've always got, if you're finding it difficult to intrude these teeth, you could go, you might use that, and we'll go through that in more different wires in module 6. We have special intrusion arches that you can use with night-eye wire, but you can do that intrusion overlay as well early in treatment.
Yeah. So
there's all these other parts of your armamentarium that you can use if you need to.
Yeah.
Okay?
Cool.
Okay. Do you feel pretty comfortable with that case?
Yeah. Yeah.
Okay. Whilst we've got you there, why don't we do your other case? Because that's a really difficult case, okay?
Yeah.
Okay. So it's a case that you're going to like, Keith.
Good.
Okay. So this guy looks a little bit younger than Keith now. Hey, Keith, it was funny. I was speaking to you. I was speaking to a guy, to Will, the other day. Who you're training with implants.
Yeah, I know Will.
Yeah, and he said Keith is so funny. I said no, he's not. So I really do want to lecture with you one day, Keith, because I think it'll be great fun. So we'll get there. So this
you can be the good-looking one. I'll be the funny one.
It's funny because usually I'm both.
Yeah.
Okay, so Becky, do you want to just explain this guy to us?
Yeah. So this guy came to us, actually. His daughter's getting Smilefast through us.
Okay, great.
Yeah, and then he came, and his presenting complaint is that he finds it really hard to keep his teeth clean. He said, obviously, he knows that once he gets the braces, it'll kill two birds with one stone. It'll improve the aesthetics as well.
Yep.
Yeah.
Okay.
I had a lot of trouble getting a good smile out of him.
Yep.
But I think the one on the right-hand side is his resting.
Yep.
Yeah.
So he lacks a little bit of incisor display at rest, but for his age, I would imagine that's probably pretty acceptable.
Yeah.
It was funny. We had a patient. We had a religious Jewish boy in yesterday that we were doing a conference for.
Yeah.
Robin and I, and this kid had I'm going to present it later on. Had a severely retrognathic mandible. I mean, severely retrognathic. And we're explaining about the chin's too far back, etc., etc. And the mother goes, it won't matter. He's going to grow a beard.
Yes.
So it was actually really a bit eye opening, because here I am trying to correct the bite, and they really don't care. But that's another story. So this guy, he's missing obviously some posterior teeth, and we talk about this in module 8. It's a term that was coined in Philadelphia called posterior bite collapse. That as soon as you start missing posterior teeth, and you've got perio issues, the bite starts to collapse, and you end up with a deepening of the bite, and normally you end up with some diastemas opening up anteriorly. I don't know whether, Keith, you would have seen that quite commonly.
I see it all the time.
Yeah, yeah. And we're going to address that in module 8 about what do we need to do, because it's a very, very common problem, unfortunately. So this guy has he looks a bit dolichofacial here,
Yes.
but he's got a really deep bite, and he's got a very deep curve of speed.
Yes.
Okay, now, and he's got obviously some wearing of his anterior teeth
Yes.
as well, and he's missing the upper left 5, missing the lower teeth, and obviously this is more Keith's area of expertise. I mean, how do you restore that just to start off with?
Well, that when they get difficult like that, it's usually an ortho problem.
Well, that's right. Well, would you say it's an ortho problem? In what way?
Well, he doesn't have really short crown height, but most people present to me with really short crown heights in this situation. And if they do, I can build them up. But he doesn't look like he needs his teeth building up. They're long enough.
Yep.
So that's why it's an ortho problem.
Okay, so you'd be looking at intruding these teeth?
Well, it depends on his complaint. So like now, I'd defer to the orthodontist, he tells. But yeah, you want to get rid of the overbite, don't you?
Absolutely. So Becky, is that what you're looking at getting? Are you looking at a cosmetic, or are we looking at both a cosmetic and functional?
No, I think it's just he just wants them to be aligned so that he can clean them properly. So I guess for me, it's more cosmetic, and he's not fussed about the posterior teeth.
Okay.
I'd be worried because one of the things I see is that traumatic palate thing. And he looks like he's going to have a trauma on his palate at some point.
Exactly.
Oh, sorry, Keith. You've just reminded me. Yes, the trauma on the palate was also his complaint. So
right.
his initial complaint. Sorry, my bad. This is just me and my brain. He actually went to. I'm his second opinion. He's been to his regular dentist, and with a swelling on the roof of his mouth, and they told him that it will come back if he doesn't correct the bite.
And I think that's probably quite true.
Yeah.
Okay, so the question now is, okay, so how do we correct that bite?
Well, with him, he definitely needs to have some sort of intrusion arch, doesn't he? But I think first of all, it's he's obviously got a lot of crowding.
Yep.
When I align the teeth, his upper teeth will actually come out, like they'll come out even more.
Yep.
Yeah.
Yep. They're retroclined.
Yeah.
Yep.
The lower teeth also has crowding though, but not as much.
Yeah, and what is once again, let's look at the canine relationship.
Yeah. So canine relationship is class 2.
Yep.
Bilaterally.
Okay. So one of our issues is going to be, okay, let's say we align him. Okay, and we just align him. He's still going to end up with overjet. Okay.
So I have to capitalize on the gap.
Well, once he's got overjet, what's going to, let's say we finish him with overjet. What's going to stop those lower anterior teeth from re-erupting?
Nothing.
Nothing. That's the problem with overjet.
Yeah.
Okay. So ideally, we want to give him anterior coupling to some degree.
So I'm thinking taking out the upper right 5.
Well, that's a possibility. Okay, but you've got a very deep bite already.
Yeah.
And are you looking at closing the upper left? Are you looking at using the upper left? Using the space on the upper left to close? Yep, you would.
Yes.
Okay.
Yep.
So we have to see how much bone is there, and how long has that been a dential site to be able to know how far, whether we can move the 6 forwards without causing a dehiscence of the bone. It looks pretty good clinically, I might add.
Yes.
So I was thinking of retracting his upper anterior segment.
You think of retracting them?
Yeah.
Yeah. Well, that's a possibility, but I tell you what, you're going to have a hard case in your hands.
Okay, fair enough.
Yeah. What would be if you've got to tell them what is the ideal treatment plan for them?
Oh, surgery.
Exactly. So the ideal treatment plan, you just put your upper lower braces on, And Keith just did the surgical one last week, okay, which is module 7. So the ideal treatment plan, be an easy case, is then braces on the upper and lower teeth. We align the teeth, and the surgeon then will move the mandible forwards, okay, and we can rotate the mandible to the point where we can extrude these teeth and give a good posterior occlusion as well.
But Jeff, how would surgery resolve this issue? Because I feel like when you look at him skeletally, he actually looks pretty okay.
Only because he's got a beard.
And that's the thing, because when I was taking the photo, I was like, this is actually really distracting for me.
Yeah, well, exactly right.
You need to have a shave and then I'll take the photos.
Yeah. So he won't see this as, this is not a facial issue. Okay, this is not a facial issue. This is, how are we going to fix this from a functional bite problem in the easiest way?
Yeah.
Okay. Easiest, most predictable way. Because you go ahead, you put your brackets on your upper arch, you've decompensated your uppers.
Yes.
He still would need an implant in his upper left 5 area, and and prosthetic replacement. Okay, that's another story. Okay, there are ways that we can do this, that we can talk about in module 8, where, let's say there's no bone there for an implant, just for argument's sake.
Yeah.
And he wanted an implant. Yeah, obviously you could do a bridge, but we could distalize that 4 back. Okay, and put the implant in the anterior region, and we've done that many times. No different to, we could theoretically distalize that 5 a little bit, and we can put the implant in here if we had to. Or sorry, that's a 4.
Yeah.
So
how long would it take you, Jeff? Would that be 6 months?
To distalize it?
Yeah.
Oh, I'm going to say, yeah, you've got to do it pretty slowly to allow the bone to form at the same time. So okay. I'm going to say it's probably, but it's probably 12 months.
Yeah, okay.
But it will be part of that overall treatment plan.
Yeah.
12 months, but you have to align those teeth first before you can start moving those teeth.
I would say I would be talking about doing it. Yeah, that's a good point. But you would have aligned them in 4 or 5 months.
Yes.
From the point of view of being able to start to open to move those spaces. So I'm thinking about 12 months in total.
Okay.
But there are some other issues, and as you do that, that crown's going to tip back. Let's say when you're talking about the upper, that crown's going to tip back. So you have to overcompensate with bracket positioning and all that type of stuff. So we go through that in module 8.
Yeah.
But I'm just trying to give you an idea that there are a lot of restorative improvements that can be done with orthodontics.
Yeah.
Okay. To make your, that's if they're going to go through an involved treatment plan anyway.
Yeah.
Then we can plan it a lot better from the restorative point of view.
Yes.
So
what if he just says no to surgery?
Okay, if he says no to that, great. If he says no to surgery, then you've got 2 other options. You basically do non-extraction, but we're left with the overjet, and he's going to be left with that. Well, firstly, I don't think you're going to level him totally, but you're going to improve it. Do you remember how I said at that? Do you remember in the last module, Keith? I said deep bites. In children, a lot of it is posterior extrusion.
Yeah.
In children, because you've got growth on your side. Yeah, with the jaws growing vertically. With adults, you don't get it. You don't get as much posterior extrusion because you don't have the growth there.
Yeah.
So most of it would have to be done through incisor intrusion. Okay. So what Becky was saying is totally correct. You're going to need your intrusion arch. You will need your lower 1925 night high reverse curves, but you're going to need to work really, really hard on getting some intrusion of those posterior teeth.
Is that why his previous dentist suggested Invisalign?
They did what?
His previous dentist suggested Invisalign, and it was going to cost him like 10 grand. So that's why he came to me for a second opinion.
This is the end of the session. Of all the cases in the world,
which I thought was nuts. But I'm thinking if you're telling me intrusion arch, and I'm just thinking you've got an extra piece of plastic in between.
It's the worst thing that can happen.
It's just going to deepen the bite, isn't it?
Yeah.
Actually, yes, it would. Yeah.
Because you get intrusion of your posterior teeth with Invisalign, which tends to deepen your bite. Unless you've got a lot of knowledge of how to do Invisalign, a lot of knowledge.
Yeah.
And I probably know of 5 people in this country that would do it. Okay.
So if you did Invisalign, you'd put turbos on the anterior teeth. They have turbos now, don't they?
Yeah, you put turbos on the anterior teeth, but you know what? This would take you, even with turbos, all turbos are doing, because you can't extrude these posterior teeth with Invisalign.
No.
Because extrusion with Invisalign is a difficult movement in any way, okay? But to do it, but all the turbos are doing is reducing the tendency for your intrusion of your posterior teeth, because when you've got your turbos on, you don't have the 2 pieces of plastic pounding together. Okay, that's if they put bite turbos on. But this would be one of the most contraindicated cases for Invisalign.
Yeah.
Are those lower incisors retroclined, or are they?
They would be.
They would be, yeah.
No, they would be. But because the upper incisors are so retroclined, the lowers would have to be as well.
Yeah.
So Jeff,
sorry, Beck. So even when you talk about Invisalign, right? How are they correcting the class 2?
I don't think they would have.
No. So now you're going to be left with overjet, and you're going to have the same issues.
So what you're saying really with this case, it's either surgery if you don't want the you don't want the upper and lower incisal relationship to be maintained like this. It really has to be surgery, because even if you do non-surgery approach, we're going to end up with a deep bite no matter what.
You're going to be working unbelievably hard.
Yeah.
Yeah. So this is a case that orthodontists don't want to treat. So what Keith was saying, if it's non-surgical, because you're going to close up your space on your upper left 5, or you're going to attempt to.
Yes.
You're probably going to need to take out a tooth on your upper right.
Yeah.
As well.
Yes.
And you're going to need to put curvus Bs in your wire as you retract, because remember, every time you're retracting, you're deepening the bite as well.
Yes.
Oh yeah.
So you're going to be fighting yourself all the time.
Okay.
I can't believe the Invisalign approach. Unless this person is one of those 5 people that I would suggest.
I don't think so. Yeah.
I wouldn't think so either.
Jeff, you just remind me, the curvus B as you retract.
Yeah.
What does that do? That's
well. In your 1925 stainless steel wire, you add curvus B.
Yeah. Okay.
So that way, it's counteracting. It'll counteract the tipping back of those upper incisors.
Yes. Okay. Got you. Right.
So you missed, I think, module 6, and we went through all of that in module 6. So you can make that up next year.
Okay.
But yeah.
So just to recap, if we're going down the surgery path, then, because that's the only, it sounds like that's the only option that we've got that can actually resolve his presenting complaint, which I completely forgot, and thank you for reminding me, Keith.
Yeah.
Then what that means is,
sorry, Beck, to rephrase that, it's the best option to resolve his.
The most predictable.
Most predictable and best option.
Yeah.
No doubt.
Then it would be upper and lower braces, just like normal.
Yep.
And then that would obviously go for, say, I don't know, well, if we're just aligning.
Usually we have the pre-surgical part, and we do this in module 7 for 12 to 18 months.
Yeah.
Then the surgery's done. And then there's usually about 6 to 8 months of post-surgical detailing.
So do we then leave the brackets on while he's having the surgery?
Yeah. Absolutely, yep. And we'll go through all that in module 7.
Okay.
But you've got this other issue, which is a severe issue. See these 8 there? See, where they do the surgery is right there.
Okay.
So the surgeon will tell you he will want that 8 out at least 12 months prior to his definitive surgery.
Yeah.
Because if you take the 8 out at the time of that definitive surgery and then do your sagittal split osteotomy, you have a great chance of fracturing the jaw.
Okay. Yes, of course.
So the other part to it will be that 8 will need to be removed, as soon as possible, because that could be also be a limiting factor as to when could the surgery be done.
If we go with non-surgical approach,
Yep.
which I know is not ideal,
Yep.
and one of the biggest things would be the fact that the bite's still not right.
Yep.
But also the lower teeth could still super erupt.
Yep.
We then say, look, you're going to wear retainers pretty much every night for life. Would that help?
Absolutely. That'll be the Band-Aid. And what you might do is wear a normal retainer, but give him a maxillary splint to wear.
Yeah.
Yeah, full coverage splint. And that'll still, at least that'll do that will be a good Band-Aid. And that would be the next that would be the other option. It's really important in a case like this to manage his expectations.
Oh, absolutely.
And for you to manage yours. Well, yeah, because this could be a Smilefast case. We'll just go ahead and line up the teeth.
Yes.
But hey, you're going to have a
massive overjet.
You're going to have a significant overjet, etc.
Not in exactly this sort of case, but what I've done in the past is built up the palatal of some of these teeth with composite and created the long centric, where you get them in class 2 protruded, and then you make every tooth so it can slide forwards.
Yep, perfect. And that's the other option. Once you've done it, it's, I suppose what you're really saying is you're going to build in a splitting composite.
Yeah.
Yeah, and this is where this whole IDT type treatment that we talk about in Module 8 comes in, because I can only do so much orthodontically. So now we start to work exactly what Keith's saying. What can we do restoratively to help this situation? And you start to work together, figuring it out. Now, in your situation, you are the restorative dentist as well. With me, I work with the restorative dentist, so I think that's fantastic. That would be a great idea. So you might compromise here, get him to wear a splint at night, or give him a long centric.
Yeah.
I would have no problems with that. When you give him the long centric, do they have posterior occlusion?
Well, you have the option of letting it over erupt or building it up at the same time. So we just let it over erupt over 6 to 12 months.
Yep.
But he's different. Like, this guy's already got full height of his teeth, so that's why it's not normal.
Yep. Right.
Normally the teeth are already worn down.
Okay. Yep. Okay.
You don't really want to make his teeth any longer at the back, do you?
What about an NTI? Is that what it is?
An NTI splint would intrude the teeth eventually, wouldn't it, if you wore it enough?
But it's only in the anterior segment.
Oh, you're saying an NTI to allow extrusion of those posteriors? Well, the same type of thing as a full coverage splint. Yeah, you could do that. I mean, you mean as a long-term retention?
Yeah.
Yeah, that's a possibility.
All right. Well, I know what to do now.
Yeah.
I need to go back and have a conversation with him.
Yeah. And if he wants to go Invisalign, just ask him to come back every 6 months so you can take photos.
You'll see him.
I think that's. You made my day, Beck.
All right, Jeff.
This is why we have to be teaching this stuff, because I just can't believe it. I can't believe it. Yeah, but Keith showed me a case the other day, which is an open bite case, significantly open bite, and ideally surgery. But we're going to do it with Invisalign, and which I have no problems in. We'll get a big improvement. But
Yeah.
this would be the exact opposite.
Asking for trouble.
Making the right diagnosis, of the case.
Mm.
But yeah, no. But remember, the other option is to take out some teeth, take out a tooth up the top, close the space. But this could be a 2-3 year treatment plan for you, Beck.
3-year treatment plan. Okay.
And you're gonna have to charge for it. He's got to understand the difficulty. I mean, it'd be a great case if you want to do it, but this will not be a financially viable case for you.
Okay. All right.
Yeah, unfortunately.
Yeah. Okay. All right. Well, thank you. I'll be seeing you tomorrow.
It is tomorrow.
It is tomorrow. I'll be seeing you tomorrow.
Fantastic. Keith, how did you enjoy Module 7?
It was very good, Jeff. I've yet to write the feedback, but it was very good. It was an eye-opener to see all that stuff.
Yeah. Well, how was the guest lecturer? He was great, wasn't he?
He was so good.
Yeah. Yeah. So, Beck, this guy is an oral surgeon in Brisbane, Terence Alexander. He gave a great presentation.
Oh.
And he's coming down to Melbourne for Module 7 next year for you guys.
Oh, looking forward to it.
Yeah, and we've actually recorded it as well, so it'll be there available for people to hear as well.
Wonderful.
Yeah, no, so you get a lot of. Hey, Beck, just very quickly, who's your oral surgeon up in Ballarat?
Mr. Graham Fowler, and there's Mr. Brent Woods now also visits.
Okay, I remember Graham, but yeah.
I actually refer to, and there's no real reason, but I tend to work with Mr. Martin Ching and.
Okay, well, Martin was in my year at uni.
Oh, there you go.
Okay, so if you wanted, if you let's say you want to do this case as a surgical case, okay, I'm happy for you to I'm happy for you to do it and hold your hand through it, and I can liaise with Martin.
Okay, beautiful. Okay.
The other guy up there is Ian Poker. He's in Bendigo.
He's in Bendigo. I don't work with him. I've worked with him in the past, but that was purely due to location. So
yeah, well, Ian was a year above me. We've been very friendly. Once again, I can help you with Ian as well if you want. Yeah. Okay, but I'm happy to liaise with Martin and help you out if you want to do, if he's willing to do surgery. This guy.
Yeah. Beautiful.
Okay.
All right. Well, thank you. Have
Okay.
a great day, and I'll catch you later, Keith.
Okay, fantastic. See you guys. Thanks for that, and I'll see Becky and Naomi tomorrow.
Will do.
Fantastic. Thanks, guys. Hope you enjoyed that.
I did. It's good.
Okay. See you later. Bye.
Bye.